Well, welcome back to our discussion on the shoulder and shoulder injuries in women. I'm here with Dr. Q and Dr. Woolridge. In this section, we're going to discuss how we treat frozen shoulder and what recovery looks like. So, Dr. Woolridge, how do you treat frozen shoulder?
Yeah, so the treatment for frozen shoulder is largely dependent on physical therapy to slowly and gently stretch and increase the range of motion of the shoulder over time. I also tell people it is a very, very slow treatment, unfortunately. This is a condition that can affect people for over a year, up to 18 months, even 2 years, through different stages. So the initial stage of this condition typically involves what we call freezing. So there's a lot of pain, as Dr. Q mentioned, this inflammatory response where we actually see that the shoulder joint in the capsule is becoming frozen. And so that comes with pain. You start to develop that limitation in the range of motion. That can last for a couple of months. After that phase, then people get into the actual frozen stage where they're not really having as much severe pain, but they've noticed that they're sort of stuck into place where they're not able to use that arm as well or use that arm through the same range of motion as they can with the other shoulder. There's not really much change that happens during that time. They're more or less sort of stuck in that phase. That can, again, last for like 4 to 9 months or even longer.
It sounds so frustrating.
Exactly. And then the final stage is really the thawing stage. So, where people start to loosen up that shoulder capsule, they start to slowly and gradually see an increase of the range of motion in the shoulder. And again, that can also last months. And so, a lot of the treatment for this, again, is a very prolonged course of physical therapy and a lot of manual stretching of the shoulder, a lot of mental and emotional support, because this can be very limiting. Like, imagine just having challenges putting on your clothes every single day. Like, that can be really devastating, really frustrating and even just hearing I have this condition that's going to last for a year or two. So there's a lot of mental and emotional support that comes with it as well of, this is going to be a long process. We're here for you. It's going to get better. But again, physical therapy is a large mainstay of our treatment. I will occasionally also offer a corticosteroid injection for the treatment of this condition, largely to reduce pain in the early stages. So I tell people this won't necessarily speed up the time course of this. This is probably still going to take a year or two until you get the normal range of motion of your shoulder back. But if you're experiencing a lot of pain, especially in that freezing stage, let's at least give you a steroid injection to calm down some of your pain and inflammation. So that's occasionally, about 50% of the time, something that I will do for my patients. There are additional treatment options that get more, I would say, potentially more invasive, a little bit more aggressive to try to actually break up the capsule and try to break up some of these adhesions, either through something we call hydrodilation, basically under ultrasound guidance, injecting a large volume of saline, of just fluid, into the shoulder to try to like pop open that capsule to allow that inflammation to release and that constriction to release. There's mixed data on the effectiveness of this, so it's not something that we always jump towards doing, but that is an option, as well as putting someone under anesthesia and, again, really manually trying to break through that tightness through the shoulder. But, again, not always something that is done, but other options that exist out there, particularly in cases where we're not seeing much progress with just time and physical therapy.
Are there specific considerations for female patients regarding management of this? Like, for example, would you ever take a surgical approach to this?
Yeah, so like Dr. Woolridge was saying, there's generally a non-operative approach to treating frozen shoulder. I also, in addition to offering an injection, I sometimes start off with just a course of an oral steroid medication taper, followed by an anti-inflammatory for 2 weeks, and that usually seems to help the pain if patients are a little bit uncomfortable or don't want to proceed with an injection just yet. So I try the medications first. And like she was saying, physical therapy is the mainstay. And we see them fairly often to check in on emotion, both emotionally and physically, look at their physical exam. And then some patients, like Dr. Woolridge mentioned, this can go on for a year or more. And so once it hits about the year mark, I just talk to the patient and I just ask them, where are you at? Are you happy with your progress? Do you think you're progressing in physical therapy? And if they are, then I say, great, keep going. But some patients, they've just hit a plateau. They've been very diligent with therapy and they just don't see any benefit from the physical therapy. They've improved their motion, but they've hit a block and they haven't gone past that block over a month or 2 months, and they're getting frustrated. And so that's when I start talking about surgery. Surgery is not used very commonly for this condition. But in those patients that have hit a year or more without progress, at that point you say, okay, surgery becomes an option for us to discuss. And the surgery, like Dr. Woolridge mentioned, it's called a lysis of adhesions and manipulation. And those scary words really just mean is I put a camera on your shoulder and I release all the scar. Like Dr. Woolridge mentioned, the shoulder has a capsule or a balloon around the shoulder that gets stiff. And that's actually very thickened. The MRI, we always say the capsule should be a little tiny pencil line. And in these patients, it's usually a very thick marker line. So you can really see where the scar is located. And in surgery, when you're releasing the capsule, it's a very thick capsule. And so you release it all the way around the socket, both the front and the back. That allows us to manipulate the shoulder. So while you're asleep, I move the shoulder up, I move it out, did all the required planes of motion, and I take photos with my camera to show you what we were able to achieve when you were asleep. And then they start physical therapy the very next day. So they wear the sling for just 24 hours, and then they start physical therapy to try and regain that motion that I got when they were asleep. Obviously, pain becomes a factor after surgery, so we start them very quickly in motion to prevent the scar from rebuilding. And most patients have a great outcome after that. Of course, no one wants to have a surgery, but after a year or more of physical therapy with no progress, some patients just say, I just want my life back. I want my shoulder back. And usually, if you've done a year of therapy and you've plateaued, the benefit of continuing is usually not great. And so at that point, we start talking about what surgery could offer them.
And what's the risk of not treating it?
The time course is really going to be what it is, right? So I tell people that, we want to gently move the shoulder, we want to try to increase the range of motion. But whether you are, diligently in physical therapy twice a week or not, honestly, the overall time course is going to be quite similar with regards to it taking a year plus to get better. We do have standard protocols for this. We know the outcomes and what these will look like if you do follow the standardized physical therapy protocol. But in general, we see that, it follows this very standardized, the condition itself follows the standard progression through the freezing, frozen, thawing. And so it's one of those things where even if you don't treat, if you ignore it, it will eventually get better. It might take a little bit longer, but it will eventually loosen up on you. Most likely. But again, to get people a more certain answer and more certainty in terms of getting their function back and getting their life back, particularly for women who are really involved in high-level activities or sports, really diligently sticking with physical therapy so we can give them a guaranteed outcome of getting better at the somewhat reasonable timeline. The physical therapy and treatment is really important. We also don't often see this recur. There are some populations, as Dr. Q mentioned, people with diabetes, for example, where we worry about the other shoulder becoming affected as well, just because there's more generalized inflammation throughout the body. Chronically high blood sugar can also cause changes in the tissues in the body that can predispose someone to frozen shoulder. So in those populations, there's some risk of recurrence. But generally, for people where this happens and strikes out of the blue, we don't necessarily see it coming back over and over again.
And is the treatment, if you did have a recurrence, let's say, or the other shoulder, is the treatment approach the same?
Yeah, we generally begin at the very, very beginning. We do the medications, we do the physical therapy, and really everyone's time course is different. It's usually about a year for everybody, but I've had some patients who it's much shorter and it's a lot quicker. Everybody's inflammation level and the way their body addresses that is very different. And so there's always a spectrum of how they present to your office. And I think sometimes this can get misdiagnosed, particularly on an MRI. If someone gets an MRI for this, yes, they'll say the capsule is thickened, but there's also a rotator cuff tear, or there's also a slap tear, which is a tear of the labrum, or there's some bursitis of the shoulder. And so some patients they do get misdiagnosed. And so I think having a good clinical physical exam when you're seeing them in the office and just noticing, that looks a little bit weird. That's not how usually that physical exam finding it shows in some patients. And so having a low index to really test the range of motion. And I think it's not always obvious in the range of motion in the planes we always check. So I always check my patients out here. So this is where they're going to be stiffer. It's called abduction, external rotation. And so out here, they're not going to be able to go up. They're going to be stuck out here. But sometimes they can rotate all the way out here. They can go all the way up like this. But if you don't test out here, you are going to miss it in some patients. And we know as surgeons, when we operate on somebody with adhesive capsulitis or frozen shoulder and we fix a rotator cuff tear, they're very stiff after surgery. And so that's something for us as surgeons to be very aware of and make sure that we are giving the right diagnosis in patients. So I think a good physical exam and just talking to the patient, listening to their symptoms can really clue you in to, is it the MRI finding or is it something more subtle that we have to, as physicians, really identify what the main cause of the patient's pain and symptoms are?